your questions. So, first question?
This is a question to the panel. What Saeed described of the neonate not being a full human yet is actually what we see here. So when we ask resident nurses, people, why the neonate, we should accept comfort care instead of going to the NICU, he belongs to his parents. When we say it's probably better this way that he dies now than later, when we say the mom's 45, she can't have another one, this baby's more precious. All these things, all the little things that you showed, that this is how we think about neonates in third world countries. This is what often we think here. And it's hard to know what to do with this. I don't know what to do with this. I certainly know, even as the mom, I would have thought it easier to see my 24-weeker die than my 2-month-old die. And it's hard to say this, but it's true. And as a physician, it's easier to see a 23-week die than a 23-week who's 5 months in the NICU. So we all have this kind of, we have eluded with these coping mechanisms in a way to make new kids. And because we make new kids and we're resistant to the death of neonates, we've propelled this thinking. It's probably inside us. It's not only ideas that we can change, it's gut feelings. And that's probably gut feelings of governments and gut feelings of the WHO initiative people. And so how do you change this? I don't know how to change this, because I cry much harder when a baby's in the unit 5 months than 2 hours. How can I cry as much when it's been 2 hours? And so how can we change this? I think from my study is to reveal this, and not to say we don't resuscitate tiny preterms because of the outcomes. We don't do it because they're not normal people. And the quote, they're not above life yet, they're interchangeable non-persons. If we reveal this bias, then we might change. But how do you suggest we change this idea that, oh, it's better they die now because they're going to die later on anyways?
So who wants to tackle the perspective question? Okay, so can you do this without your computer?
No. The computer has all the answers. So Annie, it's a great, lovely, lovely question, and I struggle with it, and I know lots of people in here do too. I think you're right. It describes a very deep evolutionary, psychological intuition inside most of us. I've had many parents whose day babies have died and under my watch who've said, this is easier than it would be, you know, if my child was older, and they find some way to cope by thinking about that. On the other hand, it's a tragedy of, you know, unimaginable proportions at the same time. And I think that, you know, so recognizing that it is part of us is one thing. And I try to suggest is I think the challenge is what bothers me about something like Jameson is when you take that idea and transpose it onto and map it onto a developing country situation, what we're potentially pulling the wool over or pulling the rug over or disguising is what Maureen and Manish were saying, and that is that 70%, 3 million of these babies don't need a lot to be, saved. Very little. Infection. I mean, giving them a friggin' antibiotic, putting a little breathing, mask on them. It's not a lot. And so it reinforces, this is my worry, I might be wrong, but to me it reinforces, it may start with a sensible intuition, but the pattern of doing that for babies that could be saved relatively easily risks reinforcing a very worrisome normative idea to me, that they're just disposable. And if they're disposable in a certain context here, they can be disposable in a broader context and a much larger scale in the rest of the world. And I think that's a moral failing. I'll just say that. I think that, I'll be very simplistic. I'm not a philosopher. But if morality is basically about how we ought to relate to one another, I think we miss that when we start to just use these justifications to let one half of the world or a much greater portion of the world live with a set of standards, and we can think about the world a little bit differently for our own. I don't know if that's adequate.
Can I have just one more response, and then I think I want to make sure we get some extra questions in. So,
I just wanted to say, I mean, I think Sad is right. But one of the things that we wrestle with is where should we place that moral outrage? And Manish and I were talking about how when baby C was dying, the team was struggling with, well, make sure the dad has time to hold him so that he can grieve the loss of his son. And dad sort of didn't want anything to do with it. And the women we've been talking to in Lusaka, one of the challenging things is we're grieved by this death. We think it's senseless. We're outraged. And the parents that we're working with and the women sort of see this as fate. And we're imposing this moral outrage and sadness and grief in the situation, and they were ready to move on to the next child. And here we are saying, hold your dying baby so that you can have these last moments. And I think, to me, that's sort of the question I wrestle with is, where do you place that outrage that is a catalyst for change? And I don't think it is on those families during those moments.
In the back?
Yeah, hi, John Lantos, just hobbled up here to ask a question.
The question's not for me, right?
I want to pick up on that last comment a little bit, because one of the things, I mean, I love the panel. Thanks for doing it, and thanks for the conference organizers for putting this in. It's really an important thing to talk about and is missing from a lot of bioethics meetings. One of the things I didn't hear was much about local leadership, and sort of instead got a sense that I think your last comment suggested that sort of we're going in with our ideas of how things ought to go and are almost sort of secular missionaries. I mean, we're sort of teaching the heathen proper ways of doing neonatal care and even proper ways of grieving and mourning. But how do you deal with the issue of whether this approach is better than, say, just giving them money and saying, it's your country, it's your babies, it's your values, we'll fund you, you come up with solutions that work for you in your culture? Isn't that, in some ways, sort of the ethically more empowering and autonomy-based approach?
I was actually going to encourage these two to talk about Abe Bang's work, because I think it would be good to illustrate just an example of how that's done.
Yeah, I guess the first answer to your question is absolutely. I think, John, the most important thing is that the solutions, the problems are identified locally. We can decide and impose what we believe to be problems on others, but if they're not owned, then there are solutions to our problems, I think is what you're saying. In the communities I've worked in Kenya and Bangladesh and Uganda specifically, working with the Ministry of Health is always the goal for many of the programs I've been involved with. And I think there is an added challenge to even caveat your question even further about it. An additional challenge that comes from outside help is that much outside help actually can undermine the local health infrastructure. So some NGOs and research endeavors that hire nurses, we're talking about a critical healthcare worker shortage. And what that feels like is one nurse, and I know a lot of nurses here, caring for 20 kids. And if that nurse can get paid a little bit more working on my research study in another part of the country, then what have I done to the local infrastructure? This is a huge challenge. I will say that from the places I've worked in, I think these are self-identified problems on a programmatic scale. I think in large part the MDGs and world leaders saying, hey, look at child mortality, we've got to do something about it, I think is becoming more on the agenda of political leaders and ministries and programs. The challenge is that there's no money to do it. $5 per person per year, you know, and how are you going to decide how to spend it? Are you going to spend it on the 2-month-old, you know, or are you going to spend it on the 33-week triplet in the hospital? So I guess I'm not answering your question, but sharing with you additional challenges of doing this kind of work, John. But I think that another piece to throw out there just to think about is how much of the aid that comes from government and foundations to help in developing countries actually, you know, helps promote me, and how much goes abroad. It's something I grapple with a lot. You know, we're sitting up here and we're all U.S. based researchers, providers, and I think this is a first step, but I think additional steps are needed. I don't know if others have thoughts on that.
Could I ask you, does throwing money at it alone really work?
Is what, I'm sorry?
Is just throwing, John asked the question, which was obviously framed probably better than I can repeat, but is just putting money to the heads of health ministries alone, is that going to address just the need?
I think there's a book that's from Zambia by Dambika Mumbazo. I think it's called Dead Aid. And it addresses, she worked with, I think, the World Bank, and she went to Harvard and very educated. But it talks about, it's on that aspect of just kind of throwing money at things, and does that solve the problem? And her vantage point is it really creates more of a problem and often can create dependency. I think money obviously is needed. We haven't found a good way to properly get funds to where often it's not, the intentions never are really carried through in the way that we would hope. And sometimes they are, but I think money is, you know, the whole money is the root of all evil. I don't think it's always evil in someone's hand, but it sure can be potential for getting used wrong or creating power, you know, jealousy, things like that, and not being used how it truly needs to be. And the other problem with it is it's sustainability. So it's you give it, but then what happens when it runs out? I'm not an economist. If Jeffrey Sachs was here, I'd probably ask him this question. But I don't know I don't think money solves it. I think it's needed, but it needs. There's so many. The roots are much deeper than that, I think.
You know, John, the only comment I have is, why do we have, it's a rhetorical question back to you or to everybody, why do we have something like the UN Convention on the Rights of the Child? Why are there universal declarations of what we all as human beings are, how we are supposed to think about and respect one another's personhood? If those exist for a reason, if they're manifesting in written form something that's universal, and they're supposed to resonate with us on a moral level, then I think it presents a challenge for the idea that, no, it's your problem, you decide what's a priority, here's a chunk of money, and we're just gonna support you in that capacity, but we're not gonna help you define what those priorities are. And I would just push it a little bit further and say, actually, at least in our experience, my experience, and Maureen showed this in her slides, that human death, is a universally grieved thing more often, often. The circumstances can color the nature of the grief, but loss is loss, and I think it's universally felt, and I think that's a starting point for thinking about more than just it's your problem, and this is just relative to you and your community.
And just a quick point, I mean, I think that the situations the programs that have been most successful are the ones where those universal declarations have been taken up by local community organization, groups of women. I mentioned Abbe Bang, both of these guys have worked with them. It's an amazing, more than decades-long program, and it's the women there who have sort of demanded more for safe pregnancy. So it's not somebody from the West or Paul Farmer coming in and saying, you know, according to this universal ethic or Western ethic, you should demand more for yourself. It came up out of the empowerment of women within those Indian districts.
Thank you. Ben?
Yeah, Ben Wolf on Seattle. Sad, I have this question for you regarding the study that you did interviewing the folks in India. I thought that I really enjoyed the slides that you presented, and the one that I had a question for you was the one that I think had the title "The Bottom Line," where it showed the attitudes of the explanations for why people had those different cutoffs, suggesting that their obligation was to try to have a healthy, productive baby. I thought I heard you describe that in contrast to what you think happens here in the United States. When I saw that slide, that resonated to me in terms of all the conversations I've had with the neonatologists who say, that's exactly why we don't do the VSD repair or don't even generally recommend it, because our obligation is to provide these healthy babies. So I'm curious, can you clarify whether you were seeing that in consistent or in contrast to what your perception of the U.S. occurs? I think it's in
play. I mean, I think that there's a battle, an active discussion about yes, medicine and neonatal care and all of pediatric care is oriented around producing and helping to enable children to reach their full potential. But I think that's the point. What is potential? Is having a disability in and of itself so problematic that the life that is left with a disability or lack of what we imagine full potential is not worth living? And I think that's where I struggle. So I would say that it's not in contrast, but where we demarcate what's acceptable and what's not acceptable in terms of living with disability is problematic, because the slightest disability or the risk of disability in a place like India where we were was enough to pull back, because the burden, perceived potential burden on these families was thought to be too overwhelming. And what I would say here is that, you know, we have had a change. Norm documented it really nicely. 30 years ago, Down syndrome, we're not going to treat it because the impact, that life potential, wasn't deemed adequate enough. Nowadays, never happens, right? We treat everybody with Down syndrome, and it's changing. So living your potential, up to your potential, whatever that is, genetically determined or anatomically or physiologically determined, creates constraints, right, on what we're allowed to say a family can choose to do or not to do. Is that responsive? Yeah.
Any other comments on Ben's question? Okay. In the back, please.
Hi, John Fanneroff from Cleveland. Really enjoyed the presentations. Thinking about how neonatology medicine has changed in the last couple of years, I wanted your comments on any on the panel of the potential. Nowadays, in a lot of ways, neonatology has gotten a little bit lower tech. Now, when babies are born, we actually put them in basically a sandwich bag, which costs pennies for thermal protection. And now when we resuscitate babies in the delivery room, we use a Neopuff, which is a relatively inexpensive ventilator that can also provide CPAP. So from those advances, and then when I was in medical school in 1998, I remember being in the library at 2 a.m., preparing to present in front of the attending. I don't think current residents know where the library is. They get all their medical information on the internet or on their iPads or on their phones, and in truth, neonatologists in India could be watching this conference right now with just a computer. So how do those advances, enhance the potential for improving global medicine?
Yeah, I think it's the focus of much attention right now. There are groups here in Seattle, including work with GAPS and a program called Program for Appropriate Technology in Health, which some of you may have heard of, or known as PATH, that is specifically looking at, how do you take simple, low-tech interventions and scale them up. So the sandwich bag's a great thought. A little cellophane goes a long ways. Take it even one step further, you don't even need the cellophane. All you need is the mom to be skin to skin with the baby, even the tiniest babies. So skin to skin plus early demand feeding and early discharge if you're hospitalized, that's kangaroo maternal care. And the challenge is getting it out to the people who need it. These babies are being born at home. So I think you're right. I think the trend we're taking in neonatology is to maybe be a little bit more minimalistic with our intervention, realizing that we don't perhaps need all the fancy stuff we needed before. The one challenge to throw out there is you know, I thought for a while as I first started doing going abroad that, you know, the answers to the problems, the list of interventions that we already know work to save most of the neonates who are dying, we know them, we just don't know how to get them out to people. And in this room, there's all kinds of wonderful scientists and researchers and advocates and care providers. In the university I work in, there's Nobel laureates. If everyone could just stop for 2 days and not run a gel and focus on 2 of these problems, maybe we'd come up with the answers. I've since learned that what we need to have is not people stop and shift attention for a couple days, but to begin to run gels on solutions, you know, on questions that are relevant to the majority of the world's problems. And so, but I think your point's a great one. I mean, Ryan showed the plastic bag as a oxy hood. Kangaroo maternal care is another great example. Bubble CPAP, you know, simple bubble CPAP is another example. You still need a compressed air source. You know, solar power, these very powerful new solar power, solar batteries are going to be great advances. Wind-up oximeters, which you can get now. Handheld ultrasound devices, which you can use to estimate gestational age or determine if a baby's breech or not very quickly. Cell phone technology, you know, for both health education and monitoring evaluation of programs. These are huge interventions coming down the line.
Anybody else?
My only comment on that is I agree, Jonathan, that I mean, we're in a transformative moment, hopefully, that will be sustained for a while. I think, and I'm just going to be, again, try to be a little contrarian. I think that there is an elephant in the room, and that's the equity gap. I mean, it costs money to create these new technologies, and the more new technologies you create, getting an expensive technology in this country to be affordable in any of these places is just a tremendous challenge. I mean, several of us have been to Haiti recently. To get a CAT scan in Haiti, it costs $200 out of pocket for a person. A CAT scan today. So you want to bring Neopuff. I'd love to bring Neopuff to these places, but it's created, our system of creating these technologies, generally speaking, outside of the academic situation, is industry, right? And that means profit making. Somebody has to generate a profit. Now, who decides how much profit is profitable? That's a hard question. I mean, I'm not saying you have to have those incentives in place. You do have to have those incentives in place. But getting somebody, whether it's a drug company or a manufacturer of a medical device, to be willing to subsidize the use of those technologies and drugs in any of these situations is just a tremendous challenge.
It's doable, though. If we can do it with scaling up care of HIV and providing ARVs, we can do it. It's that equity gap that Sad showed on a slide of, you know, the number of deaths of newborns is nearly twice that of patients living with HIV, and yet we've managed to make some big inroads in getting ARVs out to these sites. The hospital in Uganda, the first time I went, there was zero, the prevalence of HIV among the hospitalized patients was 0, because no one was being tested, because there was no treatment. Now there are 100 patients per month being started on ARVs at this rural hospital. So it can be done. It's just a matter of putting our will there.
So we have, I'm going to stop this so we can get in a couple more questions. There's somebody been waiting in the back for quite a while. Go ahead.
Dominic Wilkinson from the University of Oxford. I wanted to ask the panel about a problem that has sort of been touched on a couple of times but not addressed head on, and that's about complicity with suspect social norms. So as several speakers have alluded, there's a dilemma, especially for the outsider coming in, where we may feel that either the fact that families are having to pay for these services shouldn't be the case. They shouldn't have to be paying for the bus to get into the centre or for the care. Or we may well feel very aggrieved about the fact that if these families take home a child with disability, that they will be stigmatised, that there's this enormous, there's no ongoing care for individuals with disabilities in that community. And then we have to decide whether we take into account the factors as they are on the ground, much as we dislike them and would like them to be changed, or whether we step back from them and say we can't take these into account because they're not things with which we agree. I wondered what the panel thought about that.
Maureen, you want to try that one?
So I think the important piece is to just correct the very last thing you said, which is it's the impetus for change or for intervention isn't because it's something with which we disagree. Going back to something Sad said, I think it's just a recognition of preventable suffering, and that the women themselves, if you talk to them, recognize that this is not what they would want. They recognize that the women who do make it into Lusaka, who have obstructed labor or have a breach, come home with healthy babies, and the ones who are too far away from the hospital when this happens during delivery don't. And they ask for it, right? So, I mean, I think the issue of complicity is at the level that Saad's alluded to several times, which is, I think, sort of when those moments when everyone steps back, including, I think, those on the ground and activists within the villages. I mean, the way in which I'm using the word activist is quite broad and deep, is that they emerge in communities. So I think it's just an important shift in perspective, which is to think about complicity among those who are in a position to make a difference. Right? And that's the complicity that we're trying to use to get traction on change. And there's a real danger in acquiescing in the status quo, in inequities that could be addressed and have been addressed on TB, malaria, HIV over a few years with that effort. And I think that effort stemmed from some level of outrage and just allowing these deaths to persist.
So I've been signaled to stop. I want to thank the panelists for not only great presentations, but just fantastic responses to questions. And I think on Maureen's note, I think that there, as many of you may be sensing, there's a great now sea change and interest in maternal newborn health. There's a great passion that is developing amongst governments, NGOs, the United Nations, as well as academicians. I think the question that we're all left with is how do we harness that passion and balance it with the ethical and social justice issues, a lot of which have been raised today, and come up with an approach that will be effective, will impact lives, and that will not only save lives, but will improve the outcome of life and improve the quality of life if we do save those lives. So with that, I want a round of applause for our speakers today.